Okay, so with all your concern, we are starting today's session. So good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event, organized by Society of Onco-Anesthesia and Perioperative Care, and the topic of today's session is anesthesia for pediatric neuroblastomas. So let's begin today's session, for which I would like to hand over this session to Dr. Sohan Solanki, sir. Over to you, sir. Please proceed with your talk.
Yeah, thank you, Rupsa. So I welcome you all to this 60-second SOPSI webinar series for this um, SOPSI. And so for today's topic is, as Rupsa mentioned, is the anesthesia for the pediatric neuroblastoma, which is one of the very actually complex surgery done in the pediatric patients. And for that, we have none other than Dr. Naina Amin. She is a professor in Tata Memorial Hospital Anesthesia Department. And she is also the lead for this pediatric onco surgery, pediatric onco anesthesia in our department. And she had done, I think, many neuroblastomas in her life. So she will be the best person to chair this session. So without wasting time, I hand over the session to Naina Madam.
Thank you, Sohan, for giving me this opportunity. So I think I will start the session. So I would like to invite Sophia, who is an assistant professor in the Department of Anesthesia from Homi Bhabha Cancer Institute, Chandigarh. So she will be giving this talk, and I have gone through her slides. I think she's done a very good job. So most of the doubts should get cleared. If there are any queries, it can be put in the chat box, and we will address it at the end of the session. Okay, over to you, Sophia.
Thank you, ma'am. Thank you for the kind introduction. Shall I share my slides?
Yes.
Are my slides visible?
Yes.
Okay. So very good evening to all of you. I'm Dr. Sophia, and the topic of today's presentation is anesthesia for pediatric neuroblastoma. So in today's lecture, we'll try to have an overview of what is neuroblastoma. We'll see what it is, how it presents, how we evaluate it, and what are the treatment modalities that we are having, and what are the anesthetic management. And we'll discuss about the preoperative management, intraoperative management, and the postoperative management of the patients presenting with neuroblastomas. So to start with, these neuroblastomas, they are the embryonal tumors of the sympathetic nervous system, and they originate anywhere along the sympathetic chain. So they can present as a cervical mass, a thoracic mass, retroperitoneal, or a pelvic mass. They are the most common extracranial solid malignancy of the childhood, and the incidence is 5 to 8% amongst the pediatric malignancies, and mortality is as high as 15%. The median age at the time of diagnosis is 18 months, but in familial forms, we receive patients at the age of 9 months. So infants also come to us for this surgery. These type of tumors, they have extremely unpredictable behavior. Some of them, they spontaneously regress, some differentiate to the benign neoplasm, and some are extremely malignant, and they are refractory to multimodal therapy, including the chemotherapy, radiotherapy, and the surgery. The various sites where the neuroblastoma can present, it can originate, as we discussed, anywhere along the sympathetic chain, and they can present as the cervical neuroblastoma. 3 to 5% of all the lesions can present as a cervical mass. They arise from the superior cervical ganglion of the sympathetic chain. The cervicothoracic neuroblastoma arises from the stellate ganglion, and it extends cranially to the skull base and caudally to the posterior mediastinum. 14% of these neuroblastoma present as thoracic neuroblastoma, and they present as the posterior mediastinal mass. Abdominal neuroblastoma, they arise in the retroperitoneum, and adrenal glands are involved in 35% of these cases, and pelvic neuroblastoma accounts for 5% of these cases. They present in, the presentation is very variable. It vary from the small asymptomatic mass to a large tumor with major vascular encasement, and it can involve the spinal cord, the bone marrow involvement can be there. Some tumors, they can synthesize and release catecholamines like epinephrine, norepinephrine, and dopamine. Though the perioperative hypertension due to these catecholamines is very rare. So the incidence that is reported because of these tumors, incidence of hypertension is less than 3%. And the symptom will vary depending upon the location. The clinical presentation will vary. If it is a cervical neuroblastoma, they can present as the neck mass or the Horner syndrome. In thoracic neuroblastoma, respiratory distress, stridor, dysphagia, SVC syndrome will be there. Abdominal neuroblastoma present as abdominal distension, pain, anorexia, and vomiting. Paraspinal mass, they present as limb weakness, bladder and bowel disturbances. And 40% of these masses at the time of presentation, they have distant metastasis. So they have symptoms of distant metastasis like lethargy, anorexia, bone marrow involvement, proptosis, periorbital ecchymosis. So the presentation can vary like this. Some of the tumors, they can present in the form of paraneoplastic syndromes. Some secrete catecholamines and they mimic the pheochromocytoma. They may present as sweating, as having symptoms of sweating and hypertension, which is treated with enalapril and amlodipine, and the symptoms usually resolve after surgery or chemotherapy. Some tumors releases vasoactive intestinal peptide, and they can have severe watery diarrhea and hypokalemia. Paraneoplastic syndromes, another paraneoplastic syndrome is opsoclonus myoclonus ataxia syndrome, and it can be present in 2 to 3% of these cases. It is because there is interaction of antibodies which is produced against the neuroblastoma, and they are interacting with the normal neural tissue. So they present as nystagmus, jerky movements, inconsolable crying, and the treatment of it is the immunosuppressive therapy like pulse steroids, IV immunoglobulins. These symptoms also resolve after chemotherapy and surgery. So how to work up these patients? When these patients will come to us, the workup will include complete blood count to rule out any bone marrow involvement. Coagulation profile should be done if we are planning any biopsy, and the infantile MS stage of neuroblastoma, where the infants will present to us with the neuroblastoma tumor, they can present with spontaneous DIC. So in these cases also coagulation profile is helpful. Urinary metabolite of catecholamines like VMA and homovalenic acid, they are found in 90 to 95% of the patients. And LDH and ferritin, the high level of these things will tell us that it is having a poor prognosis and a large tumor burden. But both these are non-specific. Coming to diagnostic imaging, the imaging, the X-ray will show us a posterior mediastinal mass in case of a thoracic neuroblastoma. Ultrasound can be done. CT will tell us about the location, size, and relation of these tumors to the various structures. MRI will tell us about any intraspinal extension, any vascular involvement and metastasis. And MIBG scan and PET scan, they tell us about distant metastasis. So the role of anesthetist starts from here. Our role starts from the diagnosis itself. So non-operative room anesthesia will be required to ensure immobility while performing the scans for these procedures, or if if the oncologist is planning for any biopsy or for histopathology, in that the role of NORA is there. So most commonly used drugs is propofol, ketamine, midas, fentanyl, remifentanil. So one thing that we have to keep in our mind is that ketamine may cause hypertension in the patients who are already having hypertension, the patients who are having hypertension because of the tumor, or those who are having catecholamine release. The role of anesthesia starts early from the diagnosis in providing sedation, as we discussed, in the pain control, in giving GA for surgeries and invasive procedures, in intensive care and palliative care. So at every step of management of this complex neuroblastoma, anesthetist is involved. So it is very important to understand the pathophysiology and the treatment of these neuroblastomas. So the treatment involves a multidisciplinary approach, and the treatment will involve surgeon, will include surgery, chemotherapy, and the radiation therapy. And role of each specialty, it will depend upon the tumor staging, age, and the biological prognostic factors. So this is the International Neuroblastoma Staging System, in which neuroblastoma is graded into the 4 stages. 1 and 2 are the localized tumors, 3 is the unresectable tumor, and 4 is the tumor with metastasis. So in the low risk disease, the treatment is observation or surgery. So in the children with stage 1 neuroblastoma, disease-free survival is more than 90% with surgical excision alone. So these patients will receive only surgical modality. So chemotherapy is indicated only if there is some recurrence or if the child is having unfavorable histology. And in this low risk group, radiation therapy does not have any role. In intermediate risk disease, the patient will get a new adjuvant chemotherapy followed by maximum safe debulking surgery. So what is the role of the chemotherapy? The chemotherapy will make this tumor small and firm. There is less risk of rupture and hemorrhage after chemotherapy, and there is decreased rate of complications. The chemotherapy will shrink the tumors. And surgery is usually performed 18 weeks after initiation of the chemotherapy, so that the child at least receive 3 to 4 cycles of the treatment, depending upon the stage of the neuroblastoma. However, in the high-risk diseases, high doses of myeloablative chemotherapy may be required, followed by surgery. And after surgery, the child might have to receive total body radiation with autologous stem cell transplant. And in chemo-resistant tumors, immunotherapy is also indicated. So the treatment varies depending upon the severity and the staging of these neuroblastomas. So when this child is planned for a surgery and they will come to us in a PSC clinic, what are the considerations that we should have as an anesthetist in our mind? One is the patient might have received neoadjuvant chemotherapy, so they will be having implications because of that. Another concern that should be in our mind is the patient may have cardiomyopathy and cardiotoxicity, which can be because of the chemotherapy that the kid is receiving or because of the catecholamines that is being released. And third, the child can have hypertension preoperatively that we have to evaluate and manage accordingly. So first, coming to the chemotherapy related adverse effects. So most common drugs for neoadjuvant chemotherapy in various protocols that are being given for neuroblastoma are carboplatin, etoposide, cyclophosphamide, adriamycin, vincristine, and cisplatin. In high-dose neuroblastomas, consolidation treatment with myeloablative therapy like busulfan and melphalan is also added alongside the other chemotherapeutic drugs. And stem cell infusions is also may also be given in the high-risk neuroblastomas. So what are the side effects that we are suspecting because of these chemotherapeutic drugs? There can be bone marrow suppression, which may cause anemia, thrombocytopenia, and leukopenias. There can be a GI toxicity, which causes nausea, vomiting, diarrhea, and abdominal pain. There can be renal toxicity because of carboplatin, can have hepatic toxicity because of the cyclophosphamide that is being used in these tumors. The cardiotoxicity can be because of the adriamycin that is used in the treatment protocols. And high risk neuroblastoma, where we're using busulfan, they can have pulmonary toxicity, which the manifestations can vary from mild pulmonary dysfunction to pulmonary fibrosis with restrictive lung disease. So all these things we have to keep in our mind while doing the PSC. Second consideration that we are having in our mind is the cardiomyopathy, and it can be because of the adriamycin the patient is receiving in the neoadjuvant chemotherapy, or because the tumor is secreting catecholamine. So this catecholamine hypersecretion, they cause hyperadrenergic states, which causes chronic pulmonary vasoconstriction and coronary vasospasm, and it causes beta receptor downregulation and oxidative stress. All this will lead to myocardial remodeling and cardiomyopathy. So always remember, this cardiomyopathy, it can be present at the time of diagnosis, and it can develop subsequently during the chemotherapy also. So when the patient will come to us, serial BP monitoring and complete cardiovascular evaluation is very important for early diagnosis and for safe administration of chemotherapy also, because this can present before chemotherapy too. Another consideration that is to be taken into in mind before taking this patient for surgeries is hypertension. So 10 to 19% of these cases at the time of presentation, they can have hypertension. So mechanism can vary. It can be because the tumor is pressing on the renal vessels, or the tumor is secreting catecholamines. So because of both these mechanisms, patient can have hypertension. And if it is because of catecholamine release, the release will peak at the time of chemotherapy and at the time of surgical manipulation. So patient can have hypertension at both these stages of treatment. So the BP control perioperatively, it reverses the chronic vasoconstriction. So it reverses hypovolemia. So it is important to control the BP preoperatively. It will decreases the incidence of intraoperative hypotensions too. So for the preoperative management of this hypertension because of the catecholamine hypersecreting tumors, the drugs that are being used are alpha-1 adrenergic antagonists like phenoxybenzamine, prazosin, doxazosin, and beta adrenergic blockers may be used for the heart rate control like atenolol, propranolol. All these drugs can be used for the treatment of hypertension in catecholamine hypersecreting tumors. So the incidence of intraoperative hypertension, we'll discuss it later also, it is very less than 3%. And the intraoperatively, it will peak during the induction and at the time of surgical manipulation. So we should be ready to manage such intraoperative cardiovascular fluctuations. So how to assess this patient's preoperatively? When the patient will come to you in PSC, always check for the venous excess, look for any intraspinal extension in history. If there is any history suggestive of intraspinal extension, we should consider avoiding epidurals and consider truncal blocks for the pain management of these patients, like subcostal tap or the rectal sheath blocks. BP charting is to be checked preoperatively. Any medications that the patient is receiving for hypertension, that is to be noted. And additional airway assessment is to be done in the patients with thoracic and cervical neuroblastoma to look for any compression or deviation of the airway. The investigations that we have to check in PAC are the CBC, biochemistry like RFT, LFT, and electrolytes because the patients are post-chemotherapy, coagulation profile, 2D echo if the patient have received adriamycin or if there is any history suggestive of cardiac dysfunction or hypertension in these patients. Always look for the imaging that we have done previously to rule out any intraspinal extension because 5 to 15% of these tumors have intraspinal extension and mainly the paraspinal masses, they present with intraspinal extension. So we have to check it in the PAC itself. So after that, always discuss the surgical plan with the surgeon. So after you have done the PAC, before taking this patient, always have a word with the surgeon. What he's planning for this patient? What is the incision? What is the extent of blood loss? The possible intraoperative complications like vascular injury, need of nephrectomy. This all should be discussed previously. And the incision that they commonly take for the cervical neuroblastoma is through the neck or the cervicothoracic region. For thoracic neuroblastoma, posterior lateral thoracotomy is done. And for abdominal neuroblastoma, transpyloric or abdominothoracic incision is taken. Position during the surgery is mainly supine or lateral. So the pre-anesthesia management will include the parental counseling because it is an extensive disease, and to allay the anxiety of the parents plus means making them understand the course of the treatment is it is very important to do the parental counseling. The pre-medication that we are giving for the parental separation, it should be explained to the parents that the child will not be anxious, will be calm while going into the operation theater. The patient will receive general anesthesia. They'll not feel anything. They'll not have pain. Risk and benefits about the post-operative pain management, that will put an epidural that will be put under GA. Patient will not be having any pain while putting that. And if in case that does not work, the alternative is IV PCA. Presence of drains, catheters, need of transfusion, need of vasopressors and post-op ventilation because it can be in high-risk surgery also. So all these things has to be explained to the parent before taking these patients. The standard NPO guidelines, that is for solids 6 hours, fatty meal 8 hours, milk 6 hours, and breast milk up to 4 hours, and clear fluid up to 1 to 2 hours according to the institutional protocols. The NPO patient should be NPO according to these guidelines, and should be pre-medicated with oral midazolam, or IV sedation can also be given if IV is in situ. So while taking these patients for surgery, what are the intraoperative anesthesia challenges that we face? One is the patient is a pediatric patient. So these are not small adults. The physiology of these patients is completely different from the adults. The pharmacokinetics, the airway, everything is different. So to manage a pediatric patient itself is a challenge for us. Lengthy transabdominal retroperitoneal surgery in small children, because this long duration surgery can have a lot of heat loss. So thermoregulation, it is very important to understand the thermoregulation, maintain normothermia during the procedure for these patients. These patients can have a lot of third space losses. So maintain the fluid balance is very important, and it can be a challenge. Intermittent IVC compression while the surgeon is doing the dissection. So there should always be an eye on the BP of the patient, because while doing the retractions, the IVC will be compressed, BP will fall intermittently. So all these are the challenges that an anesthetist faces intraoperatively. Specific to these type of high-risk patients, there can be intraoperative hemodynamic instability, because this type of surgery have potential of major bleeding, because tumor often encases major vessels. Apart from bleeding, there can be third space losses, because these tumors are secreting tumors, and intraoperatively the extensive dissection can have systemic inflammatory response syndrome. Apart from hemodynamic instability, another thing that we have to consider is these patients can have intraoperative hypertension. So the incidence is rare, it is less than 3%, but if it happens, we should be equipped to manage the intraoperative hypertension with short-acting drugs like sodium nitroprusside, calcium antagonist, phentolamine. All these can be used to treat the intraoperative hypertension. Another critical step that is to be taken into consideration in cervicothoracic neuroblastoma is the dissection of vertebral arteries and the brachial plexus and the vagus nerve, and the injury to these can lead to pharyngeal dysfunction. So what is the anesthesia plan? So plan of anesthesia is general anesthesia with epidural for thoracotomy and laparotomy incisions. In thoracic neuroblastomas, there is always a possibility of airway displacement, although it is very rare and the incidence in reported literature is very less, but there is always a possibility because of the close proximity with the airway. So it should always be evaluated first. Chances of endobronchial migration of ETT during abdominal retractions. So always put your ETT and keep the cuff in the mid trachea. Don't put it too deep, because it may go in endobronchial. Too wide bore IV access, because we might have to replace the fluid and blood intraoperatively. And central venous cannulation in case the IV cannulation is difficult, and in case of high-grade neuroblastoma with vascular encasements. Intraoperative monitoring is the routine monitoring as per the ASA guidelines. Apart from that, we have to monitor the urine output, capillary refill, perfusion index and plethysmography, blood sugar. They all should be monitored intraoperatively. And invasive blood pressure monitoring, it should be done for the thoracotomy or laparotomies. For large tumors where we are anticipating major blood losses and there are pre-existing cardiac dysfunction. So in these patients, invasive BP monitoring is also done. Now, very important component is to plan the intraoperative analgesia, because pain is a major concern in these surgeries. So intraoperative analgesia is maintained with IV opioids, paracetamol, thoracic epidural. It is very important, and the level of putting this thoracic epidural is decided after discussing the extent of incision with the surgeon. Depth, as we know in pediatric, it is 0.1 mg per kg, and catheter is kept 4 to 5 centimeter inside the epidural space. Epidural infusion is started in the intraoperative period, and we can use ropivacaine or levobupivacaine. If you are using levobupivacaine, the concentration of 0.05 to 0.1% is given intraoperatively. And we have to take into consideration that we should not exceed the maximum dose for per hour. That is, if it is less than 18 months, we should not exceed a dose of 0.25 mg per kg per hour. For more than 18 months, we should not exceed a dose of 0.3 mg per kg per hour. So if in case the infusion rate we are giving, that is not covering the full incision, and we have to increase the infusion rate, so in that case, decrease the concentration of your local anesthetic. So if in case, if facial plane blocks are contraindicated, as we discussed in the preoperative evaluation. So there should be a plan ready for those cases also. A subcostal tap or a rectal sheath block should be given if epidural is contraindicated. Now coming to another important component of intraoperative management, that is intraoperative fluid replacement. So while managing the fluid intraoperatively for any abdominal surgery, we have to replace the deficit, we have to replace the maintenance and the replacement, these three things. So how to calculate the maintenance? As we all know, it is with the holiday cigar formula, the 4-to-1 formula. For first 10 kgs, 4 ml per kg per hour, next 10 kgs, 2 ml per kg per hour, more than 20 kg, 1 ml per kg per hour. For example, we are having a kid of 15 kg. So for first 10 kgs, it is 40 ml, and for another 5 kgs, it is 2 ml per kg per hour, that is 10 ml. So for a kid of 15 kg, we have to replace maintenance at the rate of 50 ml per hour. Now, how to correct the deficit? If the kid is fasting for 2 hours, and for the same kid, the 15 kg kid, the deficit is of 2 hours, then the deficit that we have to correct is 100 ml. So 50% of it is replaced in the first hour, and 25% is replaced in the second and the third hour. Very important component is the third component, that is the replacement of third space losses. These surgeries are extensive surgeries. They involve major dissections. They have major surgical dissections. So it is very important to replace the third space losses. And depending upon the extent of resection, it can vary from 6 to 8 ml per kg per hour. The fluid for maintenance that we use intraoperatively is either a ringer lactate or 1% or 2% DRL in infants and in the malnourished children. So 1%, 2% DRL, they are not available commercially, and intraoperatively, if we have to give it to the kids, we have to prepare it intraoperatively. So 1% DRL is prepared by adding 20 ml of D25 or 10 ml of D50 in 500 ml of RL. And if we have to prepare 2% DRL, the concentration of dextrose, the volume of dextrose will be doubled. The colloid of choice, if we have to give colloid intraoperatively, the colloid of choice is 4 or 5% albumin. And as it is not available commercially, we have to prepare it intraoperatively from 20% albumin. So to make it 100 ml of 20% albumin, that is mixed with 400 ml of NS, and it will give us a concentration of 4% albumin. So that can be given to these kids intraoperatively if we have to replace colloids. However, in older children, gelofusin and tetraspan can also be given, but if with gelofusin there is high incidence of anaphylaxis, and tetraspan can cause renal failure if we are giving more doses of it. Now, another important thing is the blood transfusion, because these tumors, they encase the blood vessels, they can be major blood losses in the intraoperative period. So it is very important to start the blood transfusion early. So in these patients, we don't wait for the MABL to reach and after that to start the blood transfusion. We start replacement if more than 10% of the blood volume is lost, and there are ongoing blood losses, and we are expecting that the blood loss will occur. So this is done to avoid the rapid transfusions. So, the blood replacement is started early. Now coming to the post-operative management. Once the preoperatively we have optimized the patient, intraoperatively we have managed the patient well, but the post-operative management part, it is very important for the good prognosis and good outcomes of these patients. And the post-operative management will include the post-operative ventilation. It will include the fluid management, how we have to feed this kid, how we'll manage the post-operative pain, when to mobilize these children in the post-operative period, and when to discharge. So post-operatively, these patients are having few anesthesia consideration that we all should have in our mind. If it is a cervical neuroblastoma, the patient can have post-operative Horner syndrome. Patient can have a difficulty in swallowing, can have aspiration because of the pharyngeal dysfunction, because of the nerve injury. In cervical neuroblastoma can also present with phrenic nerve injuries, and this patient may require intubation to protect the airway. So these things should be in our mind when we have operated a cervical neuroblastoma in the post-operative period. Another concern in the post-operative period is the hypovolemia. The third space losses we were talking about in the intraoperative period, the SIRS will continue, the third space losses will continue. So there are chances of hypovolemia in the post-operative period also. There can be a chyle leak, so it is very important to look into the drains. The patient can have diarrhea, so it is very important to look for the diapers, to check the diapers again and again. So the cause of this persistent diarrhea is the autonomic denervation of the small bowel. There is an extensive resection of the retroperitoneal disease around the celiac axis and superior mesenteric artery, which can cause persistent diarrhea and which can cause hypovolemia in these patients post-operatively. So first, let's discuss about the post-operative ventilation, whether these kids need ventilation or not. If it is a cervical neuroblastoma, these may require post-operative ventilation and may need an endotracheal tube to protect the airway if there is any pharyngeal dysfunction, which may lead to aspiration. So in cervical neuroblastoma, we have to keep this thing in our mind. Another thing that is of concern is respiratory distress due to phrenic nerve injury. So if there is any phrenic nerve injury intraoperatively, patient might require post-op ventilation. In thoracic neuroblastomas, the post-op ventilation may be needed for 24 to 48 hours because the lung is chronically collapsed preoperatively because of the mass effect. So patient might need intubation for some time. In abdominal neuroblastoma, the post-op ventilation is rarely required. We try to extubate this patient once this patient is warm, awake, and they are hemodynamically stable. But they might require post-op ventilation in case there is hemodynamic instability intraoperatively, which is not responding to fluids. The patient is requiring high vasopressor supports. There is moderate to severe hypothermia because the dissections are extensive. The exposure of gut is extensive in these patients. And if there are massive blood loss intraoperatively, so this patient might require post-op ventilation. So how to manage the fluids intraoperatively for these patients? So the fluid of choice postoperatively is 2% DRL. In small tumors, this low-grade tumors who are coming for the upfront surgeries, where there is not much much dissection or not much of third spacing, in those patients, according to the ERAS, means we give the fluid at the rate of 2:1:0.5. That is half of this holiday cigar maintenance for first 12 hours. But most of these patients, they are intermediate and high risk, can involve a high third space losses. Fluids are to be given at a higher rate. So we have to tailor the post-operative fluid for these patients. And this patient might require food boluses if there is an extensive surgical dissection. And in the post-operative period, we have to take into account the concealed losses, the diarrhea. We have to check the diapers, the drains, the chyle leak, the drain output. If it is more, we have to look into that also. And we have to replace fluid accordingly. Now coming to the oral feed post-operative day 1, we try to start the patient on oral feed. But if the oral feed could not be started on the day 1, we have to continue the fluids at the usual maintenance dose. That is the 4:2:1. So in the post-operative period, while managing the fluids, we have to monitor the urine output, the abdominal drains, because there can be a chyle leak post-operatively, and we have to look into diarrhea. So all these things have to be taken into account while deciding upon the fluid therapy. And every day, a cumulative fluid balance should also be checked, and we should consider giving diuretics in case the hemodynamics are stable, and we are if the patient is going into too much positive and is stable hemodynamically, we should consider giving diuretics. And if the patient is requiring IV fluid for more than 1 day because of any reason, we should consider replacing dextrose, and the potassium supplementation should be given. So the red flags here is if the patient is having persistent tachycardia, we are giving fluids and then also it is not responding. Patient is having rising lactate and there is no response to the fluid. So always discuss with the surgeon because there is a possibility of gut ischemia because the extensive dissection along the mesenteric vessel can compromise gut vascularity. So if your kid is getting sick, and you're not getting the reason, always discuss with the surgeon about the possibility of gut ischemia. So when to start the feeds post-operatively? It should be started as early as possible. While we might have concerns in starting the post-operative feeds in few patients, like in cervical neuroblastomas, there are concerns of vocal cord palsy and difficulty in swallowing, and there is a risk of aspiration. So on POD1, we start the patient on clear liquids. And if there is no aspiration, then after discussing with the surgeon, we remove the Ryle's tube after that only. And in abdominal neuroblastomas, there can be ileus because there is an extensive dissection around the gut, and there can be a delay in initiating the enteral feeds in this subset of patients. The post-operative pain management, very important component. Multimodal analgesia should be given with the paracetamol, opioids, NSAIDs if they are not contraindicated, and epidural infusion of local anesthetic in thoracic, abdominal, and pelvic neuroblastoma should be continued in the post-operative period. So in post-operative period, the pain should be measured because it is the fifth vital sign, and it can be measured in small kids with the help of flag scale that will take into account face, legs, activity, cry, and consolability. And in slightly older child, Wong-Waker faces pain rating scale can be used for assessment of this pain, and there should be adequate management of this pain with all the modalities. Another important things in the post-operative management includes early mobilization. We should try to mobilize the child at the earliest, and chest and limb physiotherapy should be started on post-operative day 1. Cure of lines. We should remove all invasive lines when they are no longer needed. And when to discharge these patients? When the vitals are stable and the patient is pain-free, and in case there is any thoracotomy have been done or there is any thoracoabdominal incision, the X-ray should show a full lung expansion in this type of patients. So to conclude, management of the patient with abdominal neuroblastoma is an anesthetic challenge, and the knowledge of pathophysiological implications and adequate antihypertensive treatment are essential for successful anesthetic management. Intraoperative cardiovascular instability may occur in this patient, and we should be ready to manage that. The team should be prepared for high volume of blood loss, requiring large volume of blood and blood product transfusion and its associated complications. Preoperative preparation and optimal intraoperative management is necessary for a better postoperative outcomes. Thank you, and regards from Homi Bhabha Cancer Hospital and Research Center, New Chandigarh. Thank you.
Thank you, Sophia. This was an excellent presentation where you have covered everything very comprehensively. So, as we all know that neuroblastoma is one of the very commonest extracranial tumors in childhood, but it is very challenging to manage these children who are coming for anesthesia. And I think if people in the audience want to ask any questions, we would be happy to take them to clarify any doubts. There are a few things I just needed to mention. When we look at neuroblastomas, when we are evaluating in our center, when we are evaluating these patients, majority, almost 70 to 80% of the children come in with abdominal neuroblastomas. The incidence of hypertension in these children is around 9%. And 5% of these children have got opsoclonus myoclonus ataxia syndrome. The most important concern for us are the intraspinal extensions, because that is what is going to decide our perioperative anesthesia management, which includes epidurals for pain management. And the incidence of intraspinal extension in our center has been around 16%. So So when we, what happens is that most of these children have been evaluated by the surgeon, has been discussed in their joint clinic, a treatment plan has been decided, and after they receive the chemotherapy, that is the time when the children get scheduled for surgery and they come to us. So when they come to us, they often have all their imaging done. So we just need to look at the necessary investigations which are relevant for us. I think few points were mentioned about chemotherapy implications. So most of the time in these children, adriamycin is, it's often cisplatin-based chemotherapy that they receive. Adriamycin is often given to the higher risk at a later stage. So we have not seen the incidence of cardiomyopathy due to adriamycin toxicity. However, there are children who come in with hypertension and cardiomyopathy, and the incidence is around 0.2% in our center of preoperative cardiomyopathy. The important thing, concern also is infants who come up for surgery. We have to be vigilant regarding them having the possibility of DIC, which even if not present preoperatively, can develop postoperatively. So we have to be very cautious regarding that, especially in infants coming up for neuroblastoma surgeries. So I think if there are any questions, we would be happy to take that.
Okay, Sophia, you can stop sharing if you wish.
Yeah, ma'am. Okay.
Can I ask something? So when you have this intraoperative hypertension, what agent do you commonly use?
So intraoperatively, ma'am, the most common that we use is the anti-G infusions.
Okay.
Most commonly, and if it is associated with the tachycardia and all, then esmolol infusion can also be used in a dose of 25 to 200 mics per kg per hour. So means the calcium channel blockers, I mean, all the drugs that we have to use should be short acting. So we if there is not much tachycardia, then we prefer to use this nitroglycerin infusions, and otherwise the esmolol infusions. Nicardipine can also be used in the form of infusion in these patients.
Anjali, I would just like to mention that in neuroblastoma children, intraoperative hypertension is extremely rare. The incidence of actual catecholamine secreting tumors may in the last 15 years, we have possibly seen maybe 2 or 3 patients with neuroblastoma who have had catecholamine secreting tumors who have come up for surgery. So often they are not secreting tumors. So they have hypertension, which is mainly resulting from the constriction of the renal vasculature by the tumors. So they get managed preoperatively, mainly with the use of amlodipine, sometimes with the use of enalapril. And intraoperatively, we have never seen a hypertensive response in these children.
Thanks.
For neuroblastomas.
Okay.
Okay. Yeah.
So I think there is one concern in everybody's mind that some cases they're difficult to manage because of significant hemodynamic instability. How often do you see that?
So basically, we used to see a lot of morbidities in the earlier years when we had started, we started doing these surgeries, and we formed a specialized DMG for that. So during that period, we used to see a lot of morbidity in terms of post-operative hemodynamic instability as well as intraoperative hemodynamic instability resulting from extensive dissection. Then we looked into our data and we talked with people in other centers, and what we realized is that the dissection happens around the celiac plexus, or so the sympathetic chain. So when the surgeon is dissecting, what he does is he keeps the entire bowel outside. The other thing what they do is often the bowels get covered with drapes and they are so busy operating they don't realize whether the bowels are getting dusky or not. And we realized that that was what was contributing to problems, because after some time when we see there is tachycardia happening intra, we ask them what is going on and we tell them to put the bowels back in. And then things, again, there is a lot of hypotension because of vasodilatation. So we made certain changes in our practice and asked the surgeon to try and avoid keeping the bowels out during the dissection. And that has made a huge difference. The other aspect is also probably during the earlier years, maybe the chemotherapy schedule which was there was not happening properly. So sometimes children used to come up for surgery and would get taken up for upfront surgery. Now, chemotherapy helps a lot in decreasing the size of the tumor, increasing the fibrosis that helps in better dissection and minimizing, blood loss and bleeding. So that probably has also changed, which nowadays, so we don't see as much hemodynamic problems with our abdominal neuroblastomas like we used to see in the past. So if these children are properly planned, receive the regular schedule of chemotherapy, and if the surgeon, while dissecting, ensures that the bowels are within the abdominal cavity and do not get exposed out for a long time, or if the bowel vascularity doesn't get compromised, because even if it gets compromised for maybe 15, 20, 30 minutes, the moment you start seeing tachycardia on the monitor, you need to think that something is going wrong. If it is not blood loss, if it is not, chyle seepage, then definitely something is happening to the bowel. So that is what we need to look at. So that is not much of a concern now with abdominal neuroblastomas.
Thank you. So if you do see the scenario, which colloid would you go for? Would you go for a colloid or?
See, often these children get managed with crystalloid boluses. It does help. But if we see that they're needing a lot of fluid boluses, then the choice of colloid often, so we are, what I practice is I tend to use albumin in children who are less than 2 years of age, because that is the practice at most centers outside, as well as at few centers, neonatal centers. So I do tend to use albumin, 5% albumin as colloid bolus. In bigger children, we tend to use gelofuscin. My colleagues who are there are happy to use gelofuscin as a colloid in children. We do not use any starch. But what we need to be aware of is the possibility of anaphylactic reactions to gelatins. And we need to be vigilant regarding that when we have to use a colloid. So if we see this patient population are nutritionally poor, they do start with a lower hemoglobin. So though the loss may not be much, whatever little losses happen is almost equivalent to a tolerable loss in these children. So we end up either giving blood, or if we have to use a colloid, then the choice in children below 2 years would be albumin, and bigger children is gelofuscin, gelatins.
Thank you. What do you think, Dr. Sophia?
Same. Most of these patients are managed with crystalloids, but yes, if we have to use, because if there are no cost constraints, we are using 4% albumin in our kids. And I have mentioned in my presentation also, if we are suspecting that there are ongoing losses, then we start the blood transfusion early if the loss is more than 10% of the expected blood volume.
Okay, thank you. There is one question from the audience.
Yes.
Do you have any experience with intranasal midazolam for CT scans or MRI in such patients, especially when the IV access is?
Sophia, do you want to answer, or should I take the question?
So we have used intranasal midazolam also, but in most of our patient, what practically I have found is the oral route of midazolam is more comfortable for the patients also, and the recovery is also good with the oral route. So we prefer giving oral than the intranasal. Nana ma'am, if you want to add?
So, yeah, no. So I don't know what they want to ask exactly. So what I would understand from this is that if the patient has got a difficult venous access and needs sedation for the imaging, can we consider doing it under intranasal midazolam? I think CT scans may be possible, but MRI may not be possible. In our center, we have the facility of giving anesthesia to these children. So if we have children with a difficult venous access, then it is the case. We take the patient under with inhalational anesthesia, put in a supraglottic airway device. However, having said that, these patients would need an IV access for giving contrast. So IV is a must. But often after we give anesthesia, we would be able to secure a line in these children. So most of the time, we do not give pre-medication in terms of intranasal midazolam or oral midazolam to these children. We take the children in the parental presence, take them under with inhalational anesthesia and do the procedure after securing an IV under inhalational anesthesia. But if you do not have the facility, you can definitely consider sedating the patient and trying to look for an IV access, because for most of these imaging, an IV would be needed for giving contrast.
Okay, yeah. Another perspective is that I think intranasal midazolam is very good in the very small children and for very short duration procedures. It wouldn't last long enough, I think, if you choose to give it for an MRI. And also, I think if the child is, the weight is more, if the child is older, then you wouldn't be able to give sufficient intranasal midazolam. Then you would have to go for oral.
Yes.
Is there any...
No, the other thing I would just like to add one more point is that considering a center that we are in, we often come across patients are very poor. They do not have the money to buy intranasal midazolam, which is expensive. It cannot be, even if you procure it, it may not be, you may not be able to use it for multiple patients because it's an intranasal spray that is being given. So we have often used oral midazolam for pre-medicating these children. And intranasal midazolam is known to be very irritant. So sometimes it is not accepted well by the children.
Yeah, that's a good point. But you could also use the 5 milligram per ml solution.
Yes.
Yeah. So if you do not have it.
Yes.
Are there any other questions from the audience? So I have just one more question. Sorry.
Ma'am, there are two questions in the Q&A.
Yeah, I saw that. Yeah, those are covered. Okay. So I just wanted to ask, so now in your practice, Sophia, how often do you see patients who have significant hemodynamic instability, you're giving fluid and nothing is coming up?
Intraoperatively, you're asking, ma'am?
Yeah.
Intraoperatively, in the cases that we have done here so far, none of them require vasopressors, but yes, intraoperatively, some patients require the fluid boluses. Apart from the normal that we are giving, the patients required fluid boluses. We have used crystalloids, we have used colloids also for these patients, and means all these patients were managed with fluids only, and we haven't started vasopressors intraoperatively in the cases that we have done so far.
Thank you. Dr. Naina, would you like to add anything to that?
Since we are a tertiary referral center, we do get a lot of high risk. So almost more than 50% of our patients are high risk neuroblastomas. And as we know, the treatment for high risk neuroblastoma is to try and achieve a complete cross total, resection of the tumor, unlike the low risk and intermediate risk where you can do a safe debulking. So most of the time in patients with high risk neuroblastomas, we do see they get hypotension in the intraoperative period, which cannot be managed just with fluids. And we often end up starting vasopressors in the intraoperative period, which is started at a low dose in the sense so the incidence of using vasopressors in our institute is around 11%.
Okay. So you wouldn't really place lines for all the patients unless you...
We put in arterial lines for all abdominal neuroblastomas and thoracic mediastinal neuroblastomas. Some abdominal neuroblastomas, if they are low risk cases and that responded very well to very well to chemotherapy, then after discussing with the surgeon, we avoid putting in an arterial line. Otherwise, an invasive arterial line, good IV access is a standard for all patients who undergo abdominal neuroblastoma surgery and mediastinal neuroblastoma surgery.
So we have another question in the chat box. remifentanil use in such kits during the intraoperative period? Has anybody used it?
I have no experience. We don't have it in our center, so I would not be the right person to answer this question.
Yeah, I think
we have not-
remifentanil is just coming.
I
So
have
most
also-
probably all centers don't have it. Yeah.
We have not used remifentanil, but if somebody have, they can use. Means we just have to give it in the infusions, but we have not because we don't have it in our center.
Yeah, it's difficult to titrate sometimes when if you don't have enough experience with it. Would you put in central lines for all of your high-risk patients?
Not for all the neuroblastomas. If we are having good peripheral lines, we are having 2 wide bore cannulas, and most of these patients, when they come to us, they come after chemotherapy. So many of these patients have already have a PICC line in situ in case we'll anticipate any problem. So it is not required in all the cases, but yes, if the patient is having difficult IV access, we have to put a central line. If the patient does not have a PICC line initially, and the other IV is also difficult, or we are expecting a massive blood loss intraoperatively, the patient is having, we are suspecting that the patient might require vasopressors intraoperatively. In those cases only we are putting a central lines.
Okay. Do you monitor PPV intra?
PPV, because it is not a validated tool to tell about the volume responsiveness in pediatric patient.
Right.
Not a validated tool to tell about these heart-lung interactions in pediatric patients. So a standard value is not seen, but yes, during the intraoperative period, we look at the trend. If the patient is having tachycardia and the PPV is also rising, so this will give us an idea that patient might be hypovolemic. So we look at the trend rather than looking at a single value, a single cutoff value for these patients. But to have a trend intraoperatively is a good idea.
Thank you, Dr. Smith. We do not have any other questions. Should we conclude the session?
So about the preoperative hypertension that you were discussing, ma'am, in our center also, most of the kids that we are receiving, they are on either on amlodipine or enalapril. But in case if we are getting the tumors which are catecholamine secreting, only on those tumors alpha-1 blockers will be indicated. In all others, we are also getting the kids on amlodipine or maximum on enalapril.
Thank you. Dr. Naina, would you like to add anything?
I would just like to say one thing is based on whatever neuroblastoma cases we have done up till now, the ones which are of major concern for us is often the cervical neuroblastomas, because we have seen a lot of post-operative complications in these patients in terms of hoarseness of voice, the respiratory distress resulting from pooling of secretions and inability to swallow, and some phrenic nerve paresis. So that is the group which we are more concerned. And I would like to stress that people, whoever is giving anesthesia to children for cervical neuroblastomas, we should not take it very lightly, considering it's a surface surgery. It can have post-operative implications. So we need to be careful and cautious when we extubate these children. If we see any signs of respiratory distress in them, then if we if we have the facility, we can put them on HFNC. If we have good recovery room facilities, if not, we would have to consider reintubation. Preferably, it may have to be a nasal thing, because nasal tubes might be better tolerated, as I think most of us would know that it is very difficult to sedate children in the intensive care unit. You would need large doses of sedation. So that is one challenge which is there, where we can possibly consider putting in a smaller size nasal tube, which may be tolerated better. And it takes a couple of days for the paresis to recover, after which the patient can go on oral. So the cervical neuroblastomas are the ones which have been a bit worrisome for us. That is what I would like to say.
Thank you for that. So there is one more question. Are the microcuff ETTs used regularly in these patients?
Yes, we are using Microsoft ETT for all the patients.
Yes.
I think there's no doubt about that. All of us are
Yes.
using.
Yes.
Okay. So if we have no more questions, then I think I would like to thank Dr. Sophia for a very comprehensive coverage of a pretty rare entity. And thank you, Dr. Naina, for your expert comments. And thank you for sharing your experience with us.
Thank you very much. Thank you, Anjali. Thank you, Sophia.
Thank you, ma'am.
I'll hand over to Rupsa from ClearNet.
Thank you so much, ma'am. Thank you so much, everyone, for giving us the opportunity to host this session. So with this, we are concluding today's session here and looking forward to host you again. Thank you so much, everyone.
Thank you.
Good night.
Good night.
Good night.